Hello everybody, my name is Markus Jörger. I'm medical oncologist at St.Gallen Cancer Center. Very happy to discuss with you some aspects of therapeutic drug monitoring in patients with, I would say, mainly advanced lung cancer. Ready for the clinic? So I hope you're ready. We can start. These are my disclosures. So what are the indications or preconditions for doing TDM? There is a set of preconditions that I think is very important that we consider and realize that. So it is obviously for drugs that have a narrow therapeutic window. This is probably basically all anti-cancer drugs, I would argue. High variability in oral absorption. Here we are talking more specifically about the kinase inhibitors. That is the topic of today, or at least of my talk. Importantly, inter-individual variability in PK should be higher than intra-individual variability. This is usually the case because, of course, inter-individual variability adds on intra-individual PK variability, but may not never be the case. Increased risk for DDIs, drug-drug interactions, or polypharmacy. That is certainly a check for the kinase inhibitors, maybe not necessarily for all anti-cancer drugs. A very important, an established PK target range and dose exposure relationship. We will see this later. This is I think an important criterion. Potentially special populations. So I will also touch a little bit on you know, like general TDM situations or opportunistic, I would call it opportunistic TDM, where we could focus maybe on special populations, for example, patients with organ dysfunction, or in our case, with kinase inhibitors, GI malabsorptions. Cumulative long-term and or irreversible toxicity. So at least the cumulative toxicity has been a recent topic of growing importance in oncology. You all realize that this was somewhat different with chemotherapy, not totally different, but particularly with the kinase inhibitors, we realize how important it is to differentiate between acute toxicity and cumulative long-term toxicity, which is an important reason that over many years and probably still the phase 1 trials somewhat overestimated the recommended dose, and this is also a base and had as a consequence FDA's Optimus program or project that asks for randomized dose optimization trials. Lack of early predictors of activity. This is certainly something that that is usually the case for our patients, for cancer patients. So let's switch gears. So I was involved with many of you probably in some activity, writing also white papers. My expertise was more in the chemotherapy field. And of course, within these groups, we considered very heavily what is good guidelines to apply for TDM in oncology. And colleagues from the psychiatric field published some guidelines on TDM. So they are going a little bit ahead because there in psychiatry you have many situations that use TDM, and here 4 levels of dosing recommendation of TDM recommendation. You can see strongly recommended level 1 here. The guidelines ask for controlled clinical trials. It's of course very important. Then level 2 would be established exposure activity toxicity relationship. So I think today probably this is still valid. Of course, there is a lot of discussion, early work, but what do we need as a basics before we go into validation of TDM or building up clinical trials. So we need a PK/PD model because that's a precondition to establish a therapeutic range. A bioassay, of course, we already mentioned that. And then the big question is, should it be controlled clinical trials? Today, there is a lot of discussion about synthetic comparators. Of course, reducing financial toxicity can be an endpoint. It has not, in my opinion, to be necessarily the improvement of clinical activity. So I already mentioned this. I think we should differentiate a little bit between routine versus opportunistic TDM. And opportunistic TDM for me would be particularly special populations like patients with organ dysfunction, increased TDI risk, frail patients, patients that already have experienced severe toxicity, where TDM could help to get more insights on the problem. Patients lacking expected activity thresholds, that's of course a difficult one because usually there we look at alternative treatment options and are tempted to switch treatment rather than to look at potential underlying pharmacological issues. Suspected compliance may be an issue. High pressure for tumor response, I think that is something that could become more important in the futures, in particular also in lung cancer, where the kinase inhibitors move to neoadjuvant regimens, and there we have, of course, a pretty high pressure to achieve a good response. So I will only touch on basically on two groups of kinase inhibitors, the EGFR inhibitors and the ALK inhibitors. Here you can see the group of EGFR inhibitors. Actually, the title is not completely correct because I recently added monoclonal antibodies, antibody-drug conjugates that are also EGFR inhibitors. So the title is still the old title. I wanted to show this table also because we have to realize, and you are certainly aware of that the therapeutic field moves, and with compounding the data for recommending or not recommending TDM, we of course always run a little bit behind the therapeutic field. And currently osimertinib is used. That may change. I will not go into that, but just that we realize that this is really a moving field. So what do we have for data for osimertinib? There is Japanese data, Japanese colleagues that established somewhat a PK target range. Here with the advantage of the kinase inhibitors is that you can pretty easily use the trough levels. And you may not even necessarily have to very stringently go for C trough, which has to be taken at steady state, obviously, before next dosing and usually in a fasting condition. So the Japanese colleagues, they established some correlation of exposure or C trough levels with either activity but also some skin toxicity. This is not so unexpected because from the first generation EGFR inhibitors we also already knew that there was at least a dose skin rash association. You can see for the second small trial, please consider the small patient numbers, there was some correlation with high and low exposure patients. This was not seen with overall survival. Then the group of ALK inhibitors, this is also a moving field. There are currently 3 very potent ALK inhibitors that at least have an FDA approval for first line. So experts in the field are discussing at times the value of one ALK inhibitor over the other one. In Europe and also in Switzerland, we usually still use alectinib in first line, and then the field is open for second line briga or lorlatinib. Just to show the group of ALK inhibitors, what do we have for pharmacological data potentially working towards TDM? Here, I think clearly we have the strongest data for an exposure activity association or relationship for both for alectinib and brigatinib, the two probably most frequently used ALK inhibitors. This is a work from our Dutch colleagues that looked in a moderately sized patient group, criso plus also alectinib, and they looked at the trough levels for both drugs. Importantly, they did random sampling, and they calculated the C-min based on a formula, so and on the average population clearance. They used this dosing algorithm that I'm showing here to achieve a minimal C trough levels. You can see here that importantly there is a wide variability in the plasma concentrations. That's something we know very well. You can see here this for criso and also for alectinib, and then in particularly for alectinib, there is a pretty good separation for the PFS curves for C trough levels, high versus low. And this is pretty intriguingly also some separation for criso, but not that impressive then for alectinib. And this actually was the base to go for a prospective randomized trial that is ongoing at the moment. Also initiated at least from our Dutch colleagues. I think some French centers have potentially joined the trial. ADAPT-ALEC, a very nice initiative that has to be applauded, a prospective randomized trial that compares standard dose of alectinib, so 600 mg BID versus a TDM that intends to achieve a minimal C trough level of 435 nanogram per ml. Also with probably the same dosing algorithm. And the primary endpoint of the trial is median progression-free survival, a pretty large trial. So this is an initiative that has to be really applauded. Now, very shortly, some data on brigatinib. There we have also positive exposure activity data. This was first shown in a pivotal clinic, in data from a pivotal clinical trial, the ALTA trial, that used 2 doses of briga in patients relapsing on crizotinib. This was done by the manufacturer, by Takeda, and Gupta and colleagues have showed that there is a correlation between the steady state C trough levels of briga and PFS, and also OS, and also an association with skin rash. These data also were the base for the step dosing, where investigators have seen that if you do the step dosing, that you can ameliorate some of the toxicities. And these data have been taken as a base for a pretty extensive simulation trial also from our Dutch colleagues. They simulated patients in 4 dosing regimens, so the approved 180 mg, the MTD dose of 240, and then 2 groups that targeted a median C trough for 180 OD or 240 OD. And this simulation trial, important, that's an in silico trial, but they showed that by the simulations you could improve PF and OS when moving from the label conformal dosing to group 4. And the average brigatinib dose was increased in this simulation trial by 70%. Here you can see that if you apply TDN again in simulations, not unexpectedly, you see that the variability decreases. And this is lastly, just to touch very briefly, of course, there is not a non-important subgroup with BRAF mutations in NSCLC, where there is an indication, at least in our country, for I think only dabrafenib and trametinib. There is not a lot of data, but again, our Dutch colleagues looked looked retrospectively at a pretty extensive group, all patients with advanced NSCLC, and they looked at those 4 protein kinase inhibitors, and they took the patients with the 10% highest trough levels and looked whether there was an association with toxicity. There was one, but only for alectinib. You can see here clearly the red bars are the patients with higher concentrations. This was not found for the MEK or the BRAF inhibitors. And just to finalize, I think I have probably one more minute. One case vignette. There are several case reports in the literature, particularly with osimertinib, so I thought I would show a known one. We do opportunistic TDM in those patients. We unfortunately don't have yet a systematic program. This is actually a female never smoker patient from the Netherlands, which lives here, presented with EGFR deleted lung cancer. She had to have initial surgery for her spine with denosumab. We initiated OSI at the approved dose. She had some skin toxicity, which got a little bit into cumulative problems. We did TDM. We found a trough level that was pretty comfortably above the target range. We reduced to 40. The patient was still moderately above the target range. Then she developed a PD after an average okay time for osimertinib. We first, we took a rebiopsy as we usually would. We detected the c-MET amplification. We first tried to dose re-escalate OSI, and as we would probably expect, we were not able to salvage her because you can see that already with the 40 mg she was above what we would consider the target range. So we had to salvage her using radiotherapy, and we were able then also to add a MET inhibitor because she had this amplification. She had a minor response. Later relapsed again locoregionally. We had to switch her to a pretty toxic triple combination where she had some, or most patients get some pretty challenging skin toxicity. We are managing that. We are still going on. She has a very good local control, recently developed brain met, which is undergoing a stereotactic radiosurgery. So just to illustrate you a little bit the complexity, and I think a pretty nice case where we found some opportunistic indications to do TDM, which I think helped the patient and was very useful. So my conclusions, outlook: the rationale for TDM is compound specific, clearly, in my opinion, and still remains for the foreseeable future, and it's based on the on the presence of a reasonable exposure activity toxicity relationship, very important. The second point is certainly food for discussion. Regulatory bodies, I think, should consider approval of a pharmacological peak attached besides a specific dosing regimen for drugs that fulfill the basic conditions. This is not yet the case, but I think is more and more discussed by FDA and also EMA. Dosing optimization is enjoying increased momentum and popularity. I think that's also very important since the introduction of FDA's Project Optimus. And I recently was able to join a very interesting discussions of the cancer medicines group from ERTC together with EMA, where this dose and treatment optimization was vividly discussed. And I think it's a good time to move the field forwards. And with that, I hope that it took me not too long, and I'm very thankful for your interest. Thanks for joining.